of the patient. Now, once you have a recurrence, what do? Still, the best chances with secondary section. The negative prognostic factors are as listed. I'll not going into the detail of these, but if you have a locally recurrent mass which is growing more than 1 centimeter, surgery is not going to do any benefit. And this is a study by Transatlantic
Sir, please
Group.
put your conclusion slide. We are running late,
I
sir.
think that next talk is
Yes,
after
sir,
this.
but we are already late. So
Okay.
please put your concluding slide.
Okay.
Otherwise, there won't be any time for any discussion, sir.
Okay.
Sorry.
So, distant metastases after secondary section are very few. It is only the local resection, and again by the histology. So, so morbidity again is dependent upon the age and organ resected. After 65 years and more organs, especially pancreas and spleen, if resected, these lead to increased morbidity. And guidelines are also, NCC guidelines are there, which says that resection is the important step. So RT and chemotherapy is only for selected results. Prostate sarcomas are not different, very short survival time, 25 months, and they on MRI, last two slides. So MRI, they are irregular masses, sometimes nodular masses, maybe heterogeneous masses, and again the absence of metastasis, stage 1, complete resection, and histology of RMS are good prognostic factors. So overall survivals are better when there was no metastasis and negative surgical margin. Age, size, and even histology were not significant. So the best treatment for prostate sarcomas is cystoprostatectomy, not a prostatectomy. So if you're doing prostatectomy, the patient will going to have a dismal prognosis of few months, but prostatectomy is a better. So the conclusion is that surgery is the cornerstone of the treatment of retroperitoneal sarcomas and prostate sarcomas, and you should try to achieve an en bloc resection with negative margin rate. And the pattern of recurrence will depend upon the histology subtype, and neoadjuvant treatment in terms of radiation and systemic therapy is being more rigorously assessed. Thank you.
Thank you, sir. 1 minute for discussion.
Sir, as you told that compartmental resection is decreasing the local recurrence rate, but before the compartmental resection, we need a biopsy. Normally in retroperitoneal sarcomas, routinely we will not do a biopsy. So what is your take on that?
So biopsy, like I told, it is very important. From imaging, so it is not always possible to, from the imaging to assess that this is going to be a sarcoma. But if you have a large mass which is encroaching upon the other organs and it's not primary organ, so in those cases at least you should do a biopsy. Biopsy is the norm in treatment of sarcomas. It has
any sarcoma presenting, we need a preoperative biopsy should be mandatory.
For retroperitoneal sarcomas, yes, you should do a preoperative biopsy.
Thank you, sir.
Thank you.
Thank you so much, Dr. Puneet Ahluwalia. We now move on to the SOGO collaborative initiatives. May I remind the speakers that each speaker has 8 minutes, which will be back-to-back, followed by 4 minutes of discussion. May I invite our first speaker, Dr. Raghavan N., who is a senior consultant, specialty uro-oncology at Apollo Hospitals, Chennai. Sir, 8 minutes. Sir, 8 minutes.
This is the most important question.
Okay, sir. I'll give you that.
First and foremost, my greetings to all. I'll come straight to the point. The most important. Can I see a pointer? Does it work? Yeah, okay. The most important aspect of SOGO is collaborative research. We all started with the fact that we quote constantly the Western data. We don't have Indian data. We need patients being treated here. Is it the same as what we see from what the Western literature are? That is the point. And we also have, sadly, a terrible record that surgeons are terrible in collaboration. That's a fact. I mean, I'm not going to disagree on that as well. So there are lots of variations in surgical techniques, the way we deal with things and whatever. So there is a thing to say that surgeons are very bad in collaboration and we can't have our own data. Inevitably, many things that are published have been a single surgeon, single institution series. So time has come that SOGO becomes the platform to collaborate, to get data across board all the centers, to see that it averages out all the biases that innately comes with a single surgeon series. So to start with, we looked at two common procedures, radical prostatectomy and partial nephrectomy. And this is an ongoing process. For each of the retrospective analysis, we need to get the permission of the ethics committee and the local center and the collaborating center. We have to have a robust data collection point, and data cleaning is the biggest hurdle in this because this is a retrospective data collection, and it has taken almost 9 months of very hard work and a lot of collaboration to reach where we are. But my request is the floor is open for all. All of you can contribute. Please, I request every one of you to contribute. Larger the data, better the analysis. So we look at partial nephrectomy, and I'm just going to be brief, and I'm going to say so far we collected from 4 centers and 675 patients. 675 patients, 4 centers, and we have another 4 centers who have collected the data, but it needs a lot of cleaning. So I have not included them in the analysis here. This is just an interim analysis, and we find some extremely interesting data sets. About 139 patients are less than 40 years. We have a lot of patients less than 50, and these are the patients we are worried about genetics. We haven't started doing genetics for them. Renal scores, just for the surgeons, they will understand the complexity of operation. At least majority are moderately complex surgeries. We are not doing simple T1A peripheral interpolar tumors. Looks like most of us are doing reasonably complex surgeries. Duration of surgery, whether you do lap or open, seems to be the same. Obviously, as expected, open surgery has slightly higher duration of surgery and slightly increased risk of complication and a percentage increase in the risk of blood transfusion. In the ISUP grading, now starts the most interesting data sets. We find that grade 2 disease is the highest, as expected, very similar to the Western literature published as well. But then look at this data set. Almost 60% of them are T1A, versus the published literature is 80% elsewhere. About 30% for us is T1B and T2. We are operating on far more complex, bigger tumors for partials than what otherwise is done. But the good news is that margin positivity for us is very similar to the published literature of only 3%. And look at this as well. Roughly, we tell our counsel patients 80% of the small renal masses are malignant, and 20% are benign. Our data shows almost 89%. 10% are benign, the rest are all malignant. So looks like our small renal masses are slightly bigger in nature. They are not small, they are moderate renal masses probably, and they are all cancers. I'm just giving glimpse of it. There are so much of data underneath which I can present. All of you will run away, so I'll just jump. And we have had good follow-up of 5 years, and looks like majority patients are doing well. We have had only 2% recurrence, which is very, very similar to what is published. So we have high-risk disease, we have high-stage disease, but looks like we are doing a decent job of it. In a bigger forum and a longer presentation, I'll share more details on this as well. So I'm just going to go to the next data set, which is radical prostatectomy data set. 2,000 patients have been enrolled for this across 7 centers. Once again, ethics approval for each center has been applied as well. And once again, another 3 center data sets are with us. We are cleaning the data, which we'll put it for the next presentation. Average age is 60, but what is slightly intriguing is that more than 80 patients have also got radical prostatectomy, which is slightly painful to see. I'm so sorry. This is data cannot lie. That's what it is. So in the perioperative variables, the majority we have are Gleason grade group 2. That's what we are doing, but equally important is GG3 as well, and GG4. So look at that data set. We are having reasonably high amount of it, and once again, more than 80 had radical prostatectomies. I'm not going to defend it in any way. That's another thing I wanted to say. Less than 60 years, we have almost So much of volume of patient. Yes, sir, that's a fact. 50 itself is so high. No, that's a PSA value less than 50. PSA value less than 50. Sir, age distribution is 2.3%. But if you take less than 60, 19 plus 2, that is about 21% of patients are less than 60 years of age. But if you look at the PSA of those patients in less than 50, PSA of less than is 34. PSA average is 34, meaning all these patients had very aggressive disease. Risk level, 52% are high risk. D-amico classification. Yeah, 52. And majority have had robotic surgery and node dissection. We have been very good surgeons. Vedang will be happy with us. Most of us are doing good node dissections. And just jumping and giving only the glimpses, post-op complication, lab had the highest complication rate at 27%. And the hospital stay for lab also was very high in spite of going through. And the lab had the lowest in terms of risk factor, but the highest in the day length of stay. Maybe many people who are doing lab have moved to robotics now, but nonetheless, that's a fact there. If you look at the T distribution, post-pathology T distribution, T2, T3 and T3A and T3B forms 50%. 1 in 2 of our patients are T3A and B. And once again, distribution across the modality of lab, robot and open. Many open surgery patients are T3B disease, vis-a-vis many lab are T2 disease. So, and you look at the margin positivity and node positivity. This is just the data showing that we are getting decent amount of nodes. About 1/5 of the patient had node positive disease, and T3B had the highest margin positivity as expected. So one last
2 minutes extra.
Last 2 slides, yeah, last 2 or 3 slides. We have a huge stage migration, pre-op and post-op. You can see that the GG2 and 3 have become so higher in the post-operative status. And going forward, this is just a starting point. The floor is open. I want all of you to participate. Please, each one of you can come up with your own plan. We'll approve, we'll support the system. We have enough people to support the system. Even the retrospective data on penile cancer, testicular cancer, nephroureterectomies, cystectomies, all are open. And please take it up, and I want all of you to participate in this. Eventually, we want to create something like a minimal data set, like what is done in the BOWS. That data set hopefully will become prospective, and we want to roll out a program where we have an online platform to enter your data as you go along with a minimum data set. It will not be a 28-page document, but at least we have something to work with. And more prospective multidisciplinary centers is monthly disciplinary trials is what we want to do. All are welcome. All new ideas are welcome. Any new ideas, please. Prospective and retrospective can be done. We will assist you in our ethics approval. Even in some amount of data collection, we can help. But intricately data collecting in each center has to be done by that center with the help of your postgraduates and others. Eventually, this will become the backbone for the Indian patients, the South Asian patients living here. I sincerely thank the SOGO for allowing us to do this, and the ethics committee, almost all of them did it for free. They are supposed to charge us. All the participating consultants and the team, they have been pestered. They will cry when they hear our name. Pavitra, who is our research assistant, like Samreen, who is our background staff, did all the groundwork, and the patients who went through all these procedures. Thank you so much. Any questions? I'm happy to answer.
Thank you very much, sir. I call upon Dr. Srinivas Chirukuri, who is a radiation oncologist from Apollo Proton Cancer Center, Chennai. So you have 8 minutes, and then we'll have 4 minutes of discussion.
I have a completely different set of slides compared to what Dr. Raghavan presented. I mean, this is just part of my own experience, and we have recently, I mean, few months back, we joined this randomized trial at our center, Prime Trial, which was, started in TMH, and then Tata Medical Center started participating in it, and we started, participating in this particular randomized trial. We've already mentioned about this particular collaborative, study which we presented.
Please
and
start the
published.
screen timer, please.
And clearly we found that there are, at least in my personal experience, I found there are great benefits of collaboration. I'm telling this to you not to, not to preach or something. This is my personal experience, and I would probably encourage people in the audience who are sitting on the fence probably to come out and, collaborate. It kind of sorts out your house in order, in the sense what kind of protocols are you following. It becomes much more clearer, and the house is clearly in order. Access to new data sets, you can analyze new things, learn new skills and expertise, expand research and impact. You can maximize your output, foster a sense of community and camaraderie between the participating centers, and this is a friendship for a lifetime. So I think these are the benefits of collaboration. And I think we have been taking baby steps. We have a small WhatsApp group which has been running for last 3 years. Those who are interested in the GU radiation oncology research, and about 20-25 of us are part of it. And we started with retrospective studies, answering some important clinical questions which are relevant to our context. And yesterday there was a discussion regarding, and Vedang mentioned regarding patients with upfront orchidectomy, what to do with them. So that could be an idea, for example, a scenario which is unique to our setting. And hopefully we will do prospective studies. Maybe it has to be limited to a smaller group, because prospective studies are not everybody's cup of tea, clearly, and I can vouch for that. And we have started this kind of an idea which about a month or more than a month ago. And T4 are not, again, very uncommon, neither in the Western setting. Western setting, it's not very common. You see, the androgen deprivation high risk T4